So computer hitches today. There we go. Okay. Good morning, everybody. Thank you for joining us. It's great to have a good friend, Tommaso Gori, who is Italian, but he works in Mainz, which is which is in Germany, close to Frankfurt. And Tommaso is a real expert in coronary intervention, complex coronary intervention, and now he's also an expert in the coronary sinus, which I didn't realize. Tommaso, it's a real pleasure to have you on and tell us about the coronary sinus reducer. Remember that many people in the US don't know about the coronary sinus reducer, so take that into account. But we hope that this device is going to be available in the context of a clinical study here. Hopefully this year, latest next year, so we'll get access to it. Thank you, Tommaso.
Yeah, Azim, thank you very much for the invitation. When you sent me the email with the invitation, I looked at the list of the people having given a talk before me, and I was a little bit impressed and scared by this. So it's really an honor to be here. I sent you two different titles. I actually have to correct you. I don't really feel that I'm an expert in anything in life, almost, not to talk about cardiology. I just have many interests. So the coronary sinus, the venous circulation, and the contribution of the venous circulation to coronary pathophysiology is one of those interests. And I find that it's really a new field and a new arena for a disease that is actually very old and but still very hard to treat. So as you said, I'm well aware that unfortunately the device that I'm going to talk about is not available in the States. The experience that we have in Germany and in Europe is built upon a few implantations. We do have several hundred implantations in Germany and in Mainz as well per year. And I got interested into the mechanism of how this device works and whether it can be applied to a slightly different condition. So before I start, I have to disclose my conflicts. I have speakers honoraria, I've received speakers honoraria, and I have a research support from Neovasc, which is a company that produces the sinus reducer. Now, this slide comes from Greg Stone, or at least a part of this slide comes from Greg Stone. First of all, I have to focus on the disease that we're talking about, and this is refractory angina. There are different definitions for refractory angina, but the simplest one and maybe the most complete is the one that says that the patient has to have angina or angina-like symptoms that have to be present for more than 3 months. Typically, those patients have symptoms that last lifelong, almost. And this is the definition of refractory. This angina cannot be controlled by means of established pharmacological or interventional or surgical therapy, including the treatment of chronic total occlusions. Now, there is a little bit of a side consideration to do about chronic total occlusions, but still, this is the official definition. Now, of course, as you know, angina has several pathophysiologies, and often the patient have pain or dyspnea because of multiple of those components. Most of the patients will have coronary artery disease of epicardial type. Several patients will have combined or isolated microvascular disease with normal or not normal epicardial coronary arteries. Many patients will have hypertrophic cardiomyopathy or hypertrophy of the myocardium, which also contributes to the lack of oxygen supply or the poor use of myocardial energetics. And some people have left ventricular diastolic dysfunction, which also contributes to those symptoms. Now, this is a definition by Greg Stone, as I said, in 4 different phenotypes of coronary phenotypes of patients with refractory angina. Patients may have isolated microvascular disease, here termed with the old definition syndrome X. There may be patients with clear epicardial disease in a limited territory, which, however, causes symptoms. There may be patients, typical those with diabetes, who have diffuse coronary artery disease that cannot undergo revascularization. And there are people with end-stage coronary artery disease, which maybe has been treated already with bypass and multiple stent implantations. Now, in order to address the syndrome, we have to know how frequent it is, and the prevalence is about over 1 million patients in the United States and about the same in Europe. The incidence is in the range of 75,000 new cases in the United States and 50,000 new cases per year in Europe. That makes about 10 to 15% of the patients, of all the patients that we see in the cath lab. As I said, this disease is multifactorial. There are patients with decreased left ventricular function. There are patients with diabetes. There are patients who also have peripheral artery disease or kidney disease. This will be a typical comorbidity. Several patients have an advanced age, and the prevalence of this disease is increasing because the population is increasing, the comorbidities are increasing, and of course we have good ways to treat coronary artery disease and epicardial stenosis. So in some, chronic refractory angina is just a little dot in the world of chest pain and in the world of stable coronary artery disease. However, this accounts still for 1 million patients in Europe and in the States, which is still a lot of people. The survival rate is, now of course this is the glass is half full or half empty. The survival rate is not that bad, 4% mortality at 1 year, in the range of 30% mortality at 9 years. This is more or less similar to what you see for coronary artery disease in general. The therapeutic goals, of course, for those patients are to relieve the angina and improve the quality of life, which is really not an easy task. Through medical therapy, of course, we don't have many weapons. Aggressive risk factor modifications, this is of course very, very important. And then, as I'm going to talk about in the next few slides, innovative revascularization or structural interventional techniques. Now, in terms of medical therapy, we are still there where we were several years ago. There are organic nitrates, long-acting nitrates, and this is could be the topic of another presentation. This was my whole PhD back 20 years back now. Another drug that we have in Europe and in the States is ranolazine. Now, this is the two latest and large papers about ranolazine. They really reflect what I also see and what my experience is. Ranolazine does not really change the incidence of hard endpoints. It improves CCS class, so it has a benefit, but many patients do not tolerate it. So the rate of patients that stop taking ranolazine is in the range of 40% at 3 years, despite improvement in symptoms. So it's a very good drug, and there are several patients that do not tolerate the side effects. Beyond the medical therapy, there are interventional treatment options. Some of them have been used but have now been abandoned and are not anymore considered in the guidelines, or at least they are discouraged in the guidelines, like transmyocardial laser revascularization. Other ones are still recommended in the guidelines as class 2A, the external counterpulsation, or as class 2B, the spinal cord stimulation. Now, for those devices, there aren't that many studies. The level of evidence is B or C. There is one randomized controlled trial for external counterpulsation. There is clear evidence that spinal cord stimulation reduces angina, but the evidence is still incomplete. Now, the device that I'm going to talk about in this presentation is this one. This is called the coronary sinus reducer. And just to introduce the concept, I will present it anatomically. This is the heart, the posterior wall of the heart here. This is the venous system, the great cardiac vein. This vein drains blood from the basically the anterior wall of the heart and the lateral side of the heart. So basically the left ventricle, at least what's important of the left ventricle. There are other veins with a different or variable distribution for the right ventricle and the posterior wall of the left ventricle. So what the device does essentially, it is a mesh device with a sand-hour shape. It shouldn't be called a stent. It reminds a little bit of a stent, but it works totally in a totally different way. The way it works is that it causes a stenosis. Once this mesh is endothelialized, it causes a stenosis, increasing the pressure distal to it. So this is the distal side. On this side is myocardium. On this side is right atrium. By implanting this device, you reduce the possibility of the blood flow to return to the right atrium and increase the blood pressure necessary to go through this stenosis. The increased hydrostatic pressure here favors the transmission of metabolites and oxygen to the myocardium. Now, if you don't believe in this concept, you probably do it because of two different considerations. The first one is that you don't believe that there is angina after you implanted a normal stent in the coronary arteries. The second argument that you may bring is that oxygen extraction in the myocardium is already maximal, so you can't possibly improve it. Now, just to quantify it, this is a paper from the 50s. This is skeletal muscle here on the right side. This is myocardium here on the left side. And if you compare the condition at rest, the myocardium is indeed more efficient than the skeletal muscle at extracting oxygen. So 60% of the oxygen that goes through the myocardium is extracted against 25 to 30% in the skeletal muscle. Under exercise, the skeletal muscle recruits more oxygen or extracts more oxygen, but the amount of oxygen extracted through the myocardium stays the same. So you might say it makes no sense to implant a sinus reducer because the myocardium extracts already enough oxygen or maximal oxygen. Now, to debate your arguments, your first argument was there is no angina after PCI. And my rebuttal is by presenting the data of the ischemia trial just recently published. So if you see the probability of having no angina here on the y-axis, so this is a probability of no angina. And this on the x-axis is the baseline angina frequency. So we are about in this range here. So there are patients who have, or in this range here, the patients with refractory angina have angina that is weekly, maybe daily, or monthly. And you see here that independently of how you treat the patients with PCI in red or cabbage in red, or with optimal medical therapy, at least 50% of the patients will still have angina at 3 months, at 12 months, and at 36 months. And those who have more angina at baseline will have more often angina during the follow-up. So the percentage of patients that profit from revascularization is high. Here is 45% of the patients that profit from PCI or cabbage, as compared to 15% of the patients that profit from optimal medical therapy. So stents and cabbage are good for symptoms, but still there is a 55% of the patients that still have angina after 3 months, a year, and 3 years. So your second argument was that oxygen extraction is already maximum. Now, this is a little bit harder to debate because you have to go into physiology. In healthy subjects, for instance, myself, as I'm talking to you and I'm recruiting my oxygen and my strengths to give this modest talk, in healthy subjects, stress leads to selective sympathetic activation, which causes a paradoxical vasodilation of the endocardial small arteries and a constriction of the subepicardial small arteries in the microcirculation. This redistributes the oxygen and the blood to the endocardium as compared to the subepicardium. And as you know, this endocardium is the area that gets ischemic at as a first step in patients with coronary artery disease, because this is the one that is worse perfused. Now, in patients with coronary artery disease, there is a combination of contractile dysfunction, there is an increase in LV-EDP, there is a rise in prearterial pressure in non-ischemic segments, and that causes a redistribution of the blood from the subendocardial to the subepicardial layers. So this is really the mechanism why patients with coronary artery disease have ischemia. The prerequisite is, of course, the epicardial stenosis in the simplest mechanism. But the real mechanism for the ischemia is that there is a redistribution of blood from the subendocardium to the subepicardium, so that the subendocardium becomes ischemic. So it's not really about oxygen extraction. It's about the fact that the subendocardial layers receive less blood than the subepicardial layers, a kind of still phenomenon. Now, to show it to you, there is a wonderful animal model of ischemia in which an LAD stenosis was caused externally, and then at the same time, the coronary sinus was occluded. Of course, you could measure by inducing an LAD stenosis, you could measure the blood flow, which dropped, and you could measure the ischemia of the myocardium. Now, what happens if you induce a stenosis? Of course, the regional myocardial blood flow drops down. You have a stenosis here, so that the flow here distal to the stenosis drops. It increases a little bit by this kind of steal phenomenon into the non-ischemic area. So this is the non-ischemic territory. The blood flow increases a little bit if you cause ischemia in the other territory. But what's more important, what changes, is the ratio between endocardial and epicardial blood flow. So this is control or baseline. There is a little bit more blood flowing into the endocardium than the epicardium. And if you induce a stenosis, the blood flow will reverse towards the epicardium, so that this ratio goes below 1. So you have an ischemia of the endocardial layer and a normal perfusion of the epicardial layer. And this is also caused by an increase in intramyocardial pressure, so that the small vessels close to the endocardium are compressed and they receive less blood. So this is graphically depicted. You have at rest or in normal people an endo-epicardial blood flow ratio of 1.2, a little bit more blood flow through the endocardium than through the epicardial layer. But if you increase the left ventricular end diastolic pressure and you cause ischemia by inducing a stenosis, then you have a selective hypoperfusion of the endocardial layer and normal perfusion of the epicardial layer. And this causes the ischemia. Now, what happens if you occlude the sinus or you reduce the sinus? This will cause a backwards pressure that keeps distended the endocardial vessels and normalizes, paradoxically normalizes the flow into the endocardial vessels. So by mechanically stretching those vessels, you actually reduce the pressure through these selectively through this layer of tissue. And this will also normalize intramyocardial pressure, so stabilize it back to normal levels. So this is again depicted graphically. If you increase the pressure here on the venous side, you will distribute the resistances again through the myocardium and equalize this resistance between endocardial and epicardial layer, so that the endo-epicardial blood flow ratio becomes again normal despite an epicardial stenosis. Now, the concept is good, the theory is there. Now, how do you achieve it in clinic? The first attempts were made in the 50s and 60s by Claude Beck, who was the president of the American Surgical Association. He actually won the Nobel Prize at the beginning of the 50s for the first defibrillation in a patient with ventricular fibrillation. And the results there were good in terms of concept, reduction in infarct size, reduction in mortality, but bad in terms of surgical possibilities. A lot of those patients died in hospital independently of the type of surgery performed. It was just that the surgical the surgery was dangerous at that time. So the concept was abandoned for several years. And the first very interesting paper, or very innovative paper, was this one published in 2007 by Banai, where he reported about implantation of coronary sinus reducer, so percutaneous implantation of a device to obtain the same result that Beck did surgically in 15 patients with severe angina and reversible ischemia. And this is the data, the raw data basically of the CCS class at implantation 3 months and 6 months in each of the patients. And as you see, the curve goes dramatically down for all patients. All patients profited basically, except for one, profited at least with 2 CCS classes. In average, the improvement was from 3.07 CCS to 1.6, something like this, highly significant, even with just 15 patients. This was a CT and MRI picture of the device implanted into the coronary sinus. And there was also in this paper a signal towards an improvement in the results in the butamine stress echocardiography, especially when this analysis was focused on the territory of the left ventricle. Now, this prompted a large trial. The trial was called the COSARA study. The study enrolled 104 patients over 11 centers. It was a prospective, of course, randomized, double-blind study, which I have to remark was sham controlled. So basically, all patients underwent a screening, and they all underwent right heart catheterization. This was also one of the criteria for the indication to implantation. And then some of the patients received the reducer. Half of the group received the reducer, and another one did not receive the reducer, but they underwent right heart catheterization, so they didn't really know that they didn't receive the reducer. So it was really a sham controlled trial, which is one of the very few ones performed in the field of coronary artery disease. Then the patients were followed up for 30 days, 3 months and 6 months to assess the effect of the sinus reducer on angina. Now, this is angina CCS classes. All patients were very symptomatic at inclusion, CCS class 3 or 4, all of them. And this is the distribution at 6 months. Of course, in the control group, this is the light blue group. You also have some patients that profited from placebo. This is symptoms. So some patients believed that they received the reducer maybe, or they were happy of attending a clinic more often. So they also felt less symptoms, but dramatically more patients that received the reducer had less symptoms. So in this study, like in all other studies, about 2/3 or more of the patients that received the reducer improved by at least 2 CCS classes. Now, this is the mean CCS class change, so an average of what I just showed you. The mean CCS class change was 3 in the, was 3 minus 2 in the reducer group, and it stayed the same in the control group. So highly significant difference. 36% of the patients improved at least two classes. 71% of the patients improved at least one class in the reducer group, many more than in the control group. Now, there was also here a signal towards improvement in several functional parameters. Exercise time improved, although it didn't reach significance. A wall motion score index focused on the left coronary artery also improved, although this was not significant. Again, this was still a relatively small study, 104 patients, and not powered for those endpoints. Now, this brought the device to the market in Europe and several other countries. Of course, this brought also more data from different registries, which essentially reproduce exactly what the COSIRA study showed, a dramatic increase in SAQ angina, in CCS class, in NIA class, and in the number of anti-anginal drugs that the patient had to take to moderate their angina. So essentially, I can summarize the several papers published. About 3/4 of the patients improved by at least one CCS class, if not two, at 6 months after implantation of the device. Now, in terms of adverse events, device success was basically in the registries and in the COSIRA study over 95% without basically any complication. Now, I've looked for the complications, of course, because I implanted, so this is the most important for me. There are several reports of embolization of the device at the time of the implantation. This happened to me as well. The device can be recaptured like any other device. It's relatively large, so it's relatively easy to recapture it. As far as I know, there is just one case of coronary sinus perforation during the implantation that has been reported, and this has been interventionally treated with a balloon and prolonged ischemia without the need of surgery. Now, this amount of data was not enough for the FDA to grant approval in the States. And I'm sincerely sorry for you. This is my personal physician opinion. Now, I know that there is a study being planned, which is called COSIRA 2, that will test in the future in the United States 190 patients, again, 190 patients treated with sham. So again, a sham control trial. And the endpoint will be CCS angina, but also instrumental measures of myocardial ischemia. So a very, very audacious endpoint. So the primary endpoint in terms of effectiveness is the change in total exercise duration in a modified Bruce treadmill exercise treadmill test at 6 months. So very, very important study that will show not only improvement in symptoms, but also improvement in this very standard way of measuring exercise capacity and tolerance. Now, the other half of my presentation, and it's only one slide, don't be afraid, was in what patients it does not work. There are some patients that are not good candidates for the reducer. This slide comes, or this graphic here comes from a paper published in the European Heart Journal. And of course, patients who have chest pain due to a non-coronary origin, they should not be expected to profit from something that treats the ischemia in the coronaries. Patients without evidence of ischemia also will not be expected to receive this device. And those who have ischemia in the territory of the right coronary artery, because remember that the great cardiac vein drains blood from the left ventricle and not the right ventricle. of course, if the right coronary artery is occluded and the right coronary artery territory is supplied by the left coronary, those patients might also profit. There is one paper where patients with CTO of the right coronary artery also profit from the occluder, but this is still an atypical indication, so to speak. The other point are patients with compromised left ventricular ejection fraction or with a right atrial pressure larger than 15 millimeter of mercury. There are two different reasons for the failure of the sinus reducer to work in those potential failure to work in those patients is that those patients have symptoms that depend on the heart failure rather than on the ischemia. And those patients with an increased right atrial pressure probably already have a pathological reducer, so their pressure in the coronary sinus is already elevated and cannot be elevated further. Now, this is the group of Milan. They developed an interesting tool to see to predict whether the coronary sinus reducer will work. So basically, what they do is they occlude the coronary sinus and they see if the patient develops an increased blood pressure distal to the balloon. So if there is no blood pressure, you would expect that the blood is drained through different pathways from this great cardiac vein, and of course the occlusion of a vein that is not necessary for draining the blood from the left ventricle would also not be expected to bring any major advantage. Now, the last indication that we are trying to study is the field of microvascular angina. Now, this will deserve a very, very long discussion. There is evidence that also patients with microvascular angina might profit from the coronary sinus reducer. And this is mechanistic evidence from our own lab. We have several patients of this type. This is an IMR, so an index of microvascular resistances measured before sinus reducer implantation and after sinus reducer implantation. So there is a drop, a paradoxical drop in microvascular resistances. The field is a little bit complicated. It's not worth starting now to explain it because it's quite complicated and I'm not sure that I understand it myself, but it appears to work. So this is also a good indication for the field. Now, summarizing very shortly, good candidates for the reducer are patients with chronic refractory stable angina, CCS class 2 to 4, who are on therapy already, of course, patients who have an objective evidence of reversible ischemia, who have an ischemia in the left coronary artery district, who have a left ventricular ejection fraction of larger than 30 or at least no heart failure, and who have a normal right atrial pressure. If you implant following this indication, then you would expect that 3/4 of the patients will have at least one CCS class reduction, so a marked improved in angina. Just 2 slides to show how this is implanted. And if I'm running late, just tell me, please. So first of all, the coronary sinus is intubated with a multi-purpose catheter. Then there is a little bit of contrast to detect the anatomy or to describe the anatomy of the vessel. The sheath is brought forward. This is a 9 French sheath. The device is brought forward. The first 2 dots are the proximal and distal end of the device before implantation. So this is carried forward, and then the sheath is retracted to allow the balloon mounted device to be implanted. This is what happens here in this little video. This is a coronary sinus reducer being implanted ex vivo, of course. This is the device. The balloon is then deflated. And if Microsoft helps, I see that it's hanging a little bit. Exactly. So it looks with the balloon. The balloon is then deflated balloon is then retracted, and you will have this kind of appearance with a flow that is in both directions, of course, slower because of the occlusion caused by the reducer. Now, the very last question is, how do I find patients for this device? You have to have a good advertising or information system. You have to talk about with your referring physicians. You have to give them feedback after follow-up, yeah, and you have to ask for follow-up from them, because they will see the patients back. You have to have your colleagues in the chest pain unit and the cath lab and the ward well alert of this of the existence of this device. You have to have a refractory angina clinic that follows those patients, and you have to have a series of exams that you perform before implantation in order to be sure that the indication is there. So just remember, you told me that angina after revascularization does not exist. Actually, angina after revascularization is very frequent, and about 50% of our patients do have angina after implantation, after normal stent implantation. So they are potential candidates for at least follow-up, and in severe cases, there are patients who might profit from a coronary sinus reducer. For the coronary sinus reducer, there is a physiological rationale, and there are robust data from a sham controlled trial and another sham controlled trial that will follow up. So just remember, my very final statement is that patients don't have angina until we ask them. And it's very important to follow up on our patients that receive conventional arterial stents and see and make sure that they don't have symptoms. If they do have symptoms, and that happens in 50% of the cases, they might be candidates for some more treatments, including the coronary sinus reducer. So thank you very much.
Thank you, Tommaso. That was excellent. I worked in Milano with Francesco Giannini, so I got to see a lot of these implants, and I've been surprised about how good a lot of the clinical data has been so far, particularly in the sort of respective registries that you guys are doing in Europe. I know that Francesco also has some MRI data showing differences in ischemia. So I think for me, there's been no doubt that the device, has a function in refractory angina patients. I don't know what you think, Juan.
No, I agree. There's a lot of good biological data and experimental data that supports this approach. One question I have, Tommaso, and I think you touched on that, is how do you actually select the right patient in terms of the clinical workup and indications and physiological assessment that could potentially predict the patient that is going to improve after implanting the device?
Yeah, so of course we talk about non-COVID times, right? Because everything has changed now with COVID. It's really hard to treat patients who are not emergencies in Europe, like in the States, like in the rest of the world. So the first point is that you have to have a system where colleagues are aware of the existence of this device, who are motivated because they know the data, and the data are, as you agreed, are outstanding for this device. So you have to motivate your referrals with follow-up data, and contact them continuously. I called it advertising. Of course, it's no advertising. It's information between colleagues, of course. Now, when the patients come to this clinic that we established as a refractory angina clinic, so it's really a tertiary clinic. It's not just a clinic for every patient. All patients undergo a stress test all patients undergo an MRI because we also want to study in a non-invasive way the microvascular function and perfusion. All patients undergo a cardiopulmonary exercise test and, of course, a normal echocardiography. We want to exclude, and of course, also a spiroergometry. So we want to exclude patients who have pulmonary problems. We want to exclude patients who might have dyspnea because of heart failure rather than angina, and we want to capture those patients who have ischemia in the left coronary artery territory and not in the right coronary artery territory.
Yeah. I think that's an important part. Also, that it generally, I mean, it works for patients who have ischemia in the left coronary artery territory. If it's Tommaso, I was looking at some of the the data published by Giannini and Baldetti about balloon occlusion. Do you think that could be an easy way of predicting responders? Because it just seems you are going to go into the coronary sinus, you inflate your balloon, you look at what occlusion pressures are, and you have an easy way of hopefully. Has that been validated by others?
Not that I know of. I've been trying to do some measurements. I actually started doing before I implant the device to just start. I just started occluding the coronary sinus with a normal Swan-Ganz catheter and just measure the distal pressure as we would do it for a normal right heart cath in the occlusive position. And I do see some differences between patients. I can't really relate to the effectiveness of the device during follow-up.
Right.
I can't really answer, but it's an interesting concept. Of course, if there are collaterals to the vein that you're occluding, of course you can't expect the device to work. Yeah.
Right. There are a whole lot of questions from some of our colleagues, so I'm going to pose some of them to you. The first is there any antiplatelet therapy needed after implantation? And if so, is there any data to support how long you give antiplatelet therapy for?
Yeah, I'm not sure about the data. There is no case, as far as I know, of thrombosis of the coronary sinus. And what we do and what is suggested by the producer, by the manufacturer, is aspirin. Of course, all those patients receive aspirin anyways. Mm-hmm. and dual antiplatelet therapy with clopidogrel most of the cases for at least 6 months. So it's just like for a coronary artery stent. Yeah.
Okay. Perfect.
Of course, patients who have atrial fibrillation undergo a single antiplatelet therapy for 6 months and anticoagulation, just like for stents. Yeah.
Yeah. Then there's a question from Scott. What is the effect of occlusion on collateral flow? And what percentage of responders had occluded coronary arteries in the left coronary artery distribution?
Yeah. So the question of those are complex questions. Yeah. So on collateral flow, it depends, of course, on in which direction the collateral flow flows. Yeah. so an occluded left coronary artery, if you have collaterals from the right coronary artery to the left coronary artery, you would actually have to think about it. Yeah, it's really good question. You would actually increase the subendocardial flow through the collaterals, and actually probably favor the collateral circulation, because you reduce the microvascular resistances. Yeah, so whichever direction they're going, the blood is flowing from, whether from arterial to venous or from arterial to arterial through microvascular collaterals, it should actually be improved. Yeah.
What about left to left?
Data, but it's really interesting.
Okay. Would it be different left to left versus left to right collaterals?
Left to left would probably not be improved, or not changed and not worsened. As I said, there is a paper testing the efficacy of the sinus reducer in patients with occluded right coronary arteries. Now, of course, there is no rationale of a sinus reducer to actually improve the perfusion in the right coronary artery distribution. But if you favor the distribution of oxygen and the uptake of oxygen in the left coronary circulation, that there will be more oxygen for the right coronary shunted to the right coronary circulation too. So those patients profit from the sinus reducer as well.
Increased collateral flow, probably.
If there is collateral flow, of course.
Yeah. Okay. And so you've not seen data so far. There's no data on patients with CTOs who then get a reducer and come back and have been seen to have better collateral flow. No, that observation hasn't happened.
I'm not sure. I don't know the data. I know that those patients profit. There is this one paper, and I also have some patients with CTOs that I treated this way. Yeah. I know that they may profit from it. I'm not sure about the straight away about the collateral flow. I would say that it improves.
Right. And also from one of our intervention fellows, Manav, great talk, and thank you for the in-depth physiology explanation. So he's got a couple of questions. So the first one is, he says, how long until you see benefits? Since the cells are open after implantation, he, like many people, I think, are surprised to see that there's a change in flow immediately post-implantation.
Yeah, that's true. There is actually, in most of the patients, there is no change acutely after the implantation, but you try and implant the device on a valve. So actually, by implanting the device on the valve, you actually have a stenosis right after the implantation. And the reason to implant it on the valve is that you have a more stable grip on the device at the time of the implantation. So you actually do have some hemodynamic effect right after the implantation in some of the patients. Yeah.
Okay. And then, are there any concerns for long-term issues with venous congestion, or are there reports of the coronary sinus occluding? Could it occlude the venous system?
No, there are no cases.
Okay, so we don't know yet. No reports.
We don't know yet.
Right. Yeah. Then there are a couple of questions about the coronary, CRT of the coronary sinus. So if a patient has a lead, is it a contraindication? If a patient needs CRT and you put in the coronary sinus, how long do you wait before you can put in a lead through the reducer?
Yeah, that's of course. So it is officially a contraindication. We haven't had the case yet. We had one patient where both devices were indicated based on the refractory angina and the need for a resynchronization, and we decided to do first the resynchronization, and the patient had no symptoms afterwards, so then it didn't get the reducer. Okay. Our strategy was to implant the CRT first, let it grow into the tissue, and then implant the sinus reducer thereafter. I know that there are centers who have done the opposite. Of course, it's a mesh device. When it's endothelialized, you can cannulate it again and dilate it again with a balloon if you want to put a CRT through it. Okay. I wouldn't expect it to be very different or very difficult. Yeah. So you will need to dilate it and then implant a CRT.
Okay, so that's important. You'd probably have to dilate it and then get the CRT. And if you dilate it, then you lose the effect of it, right?
Yeah, you probably will need to dilate it to not to 7 or 8 millimeters like a normal original coronary sinus. You will probably dilate it to 4 or 5, as much as you need to get through with the lead, and then leave it like this. Yeah.
Right. I see one last question, and this is from one of your mentees, from Andrea Buono, who says hello to his mentor and to one of his great masters, and he asks. I left his question for last, for good reason. So Andrea asks, is it time for a randomized controlled trial comparing CTO recanalization and coronary sinus implantation?
That'd be nice. That's an idea. Maybe.
But I mean, in the end, right? I mean, the only thing consistently in most patients, the randomized studies they've been able to show with CTOs is symptom improvement, right?
Yeah.
This device also causes symptom improvement.
Yeah.
So, you know,
Yeah.
I don't think it's beyond the realm of what we should be doing in the future.
No. It's so there is a rationale, right? It's we've been looking for prognostic improvement with CTO recanalizations for years, and you probably need a study with 10,000 CTOs performed
That's the problem.
to show an improvement in prognosis. So
That's
why
the
not?
problem.
Yeah.
Yeah.
Why not?
So it's a much quicker and safer procedure.
Definitely. That by far.
Right.
So you can implant a sinus reducer in as a procedural time is less than half an hour,
and
we all
patients
know.
go home the same day.
No, we keep them because of DRG issues, actually.
Okay.
So
in America, we
has to
send
stay in
home the same
hospital.
day.
Yeah, but that's another consideration. Yeah. But of course, it's otherwise the day after is really no problem. Yeah.
Tommaso, thank you very much. It was really fascinating. It was a great talk, really building it up from, you know, refractory angina, the pathophysiology, and the pathophysiology of the coronary sinus reducer to the clinical data and responders. We all learned so much. So really, thank you.
Thank you very
Take care
much.
and stay
Thank you
safe
very much.